Good morning, everyone, and thank you again for the invite. I'm a midwife by profession, but don't hold that against me. I've had the pleasure of leading neonatal education in Northern Ireland for over 30 years now. And so my foray into paediatric or children's palliative care is very recent. But I have to say that I've been humbled by how welcome I've been made to feel, and I'm learning all the time, so please be gentle with me. So, over 95,000 babies in the UK are admitted to neonatal units every year, which is a huge number. In 2005, the Embrace found that there were more than 4,400 extended perinatal deaths in the UK. And sometimes we look at those figures, they are quite startling. Neonatal palliative care has received increased recognition recently, over the last few years. It's still in its infancy, excuse the pun, in Northern Ireland, but we have undergone a number of key developments. We've had the introduction of the NICE guidelines, the Together for Short Lives pathways, the involvement of neonatal linked nurses in UK children's hospices, although we haven't got round to that just yet in Northern Ireland. And we've also had the Pan-London nurse consultant, Alex, and that has had probably one of the most significant impacts on how we're currently trying to develop our neonatal care pathways. I'm sure Alex won't mind me telling you that she's in the process of editing a neonatal palliative care textbook, so look out for that next year. Wee plug there for you, Alex. But there are indeed complexities inherent in neonatal palliative care, and they have hit the headlines more recently with the Charlie Gard case. Naturally, that has been a fairly traumatic experience for a lot of the carers of Charlie and the family, of course, but it's likely to have an ongoing impact, I would say, on us as carers in neonatal units and indeed parents who are faced with similar situations. So is the neonatal unit suitable for end-of-life care? Well, I suppose it depends on what we mean by end-of-life care. I know all of you professionals are here today to talk more about palliative care, but with babies, naturally, there are end-of-life situations that happen very, very quickly, where we don't have an awful lot of time for planning, and it ends up almost as an emergency situation, which is unfortunate. But there are more and more cases, because we're delivering babies now and caring for babies as early as 23 weeks gestation, that are very much on the edge of viability. And some of those babies will be left with conditions that can indeed shorten their lives, or diagnosis will be made during pregnancy of babies that will have a shorter life than normal. So I don't always think that neonatal units are the most suitable place for end-of-life care. They're noisy, they're very busy, and there's always so much going on. Quite a lot of families who have lost babies in neonatal units would say that they find it quite disturbing in some respects, that even though their little baby is dying, in the midst of all this busyness, that life is going on for so many other people around them, and that can be very hurtful for them. So is there flexibility in our care provision and family involvement? Well, not always. Unfortunately, our care regimes in the neonatal unit, intensive care particularly, can be quite rigid in relation to how often observations are carried out, how often feeds are done, nappy changes, etc. So, there's not a lot of flexibility there, not as much as there should be. There are large numbers of staff, so continuity of care for parents is not always easy to achieve. And we have to look at the neonatal nurse's experience of end-of-life care. Some staff will be very experienced, others will be much less experienced, and that can be very frightening for them. And we need to think about collaboration with other disciplines. It needs to be more of an interdisciplinary approach. In carrying out this study, I carried out a literature review, and I would have to say at the outset, they say you should never apologise before you start to give a presentation, but I am going to apologise because I am not a researcher. And having done this short piece of research, I am in awe of people who do research as a full-time job. It was the most stressful and frustrating period, I would say, of my career. And it's a very short study, but I do feel, being a person who likes to work at grassroots level, that it did allow the voices of these more junior nurses to be heard. But looking at the literature, it does show very clearly that caring for dying babies is extremely stressful for neonatal nurses. And much of the literature around it, though, when you looked at it, was really based on decision-making and more ethical type issues and parental involvement. There wasn't really an awful lot about how nurses felt when they were put in this position. There was evidence regarding professionals' experience, and it suggests that lack of confidence in caring for these infants is very much a big factor. So the aim of this study was to look at the anxieties of nursing staff and their educational needs. We wanted to address the gaps that there was in the knowledge, and I think that this study explores very effectively the anxieties of these more junior members of staff in providing end-of-life care and addresses their education and professional needs. And the ultimate aim, of course, is for all of us to provide the very best care that we can for babies and their families. So the methods, well, I'm not a number cruncher, I'm absolutely hopeless at maths. So this was very much a qualitative methodology. I wanted to hear from these nurses to hear what their experiences were. Ethical approval was granted, and we used 2 focus groups. It was quite a small class. It was really my students, so they didn't really have much choice, bless them. And they were kind of coerced into, well, I shouldn't say that was a piece of research, I suppose, but that sounds very bad. But some of them actually teased me and said, Sharon, if we help you with your study, will you give us an extra few marks on our assignments? To which the answer was no. But they still helped me anyway. They were very good. So we had 2 focus groups, and we adopted the nominal group technique to collect the data from the students. There was a class of 17 nursing students, but there were only 12 of them who actually had less than 3 years' experience within the specialism. And unlike Alex with the problem of over 30 neonatal units, across the whole of Northern Ireland we only have 7. So I was quite fortunate in that I didn't have to deal with very big numbers. So each group consisted of 6 participants with 2 facilitators. Professor Jane Price, some of you might know her, she's currently based in Kingston University, was one facilitator and I was the other. So we used a nominal group technique and we asked 2 questions. Question 1, we asked them to consider the challenges regarding their practice and in relation to end-of-life care in the neonatal unit. And question 2 was, in light of these challenges, whatever they might be, we wanted them to consider what future developments they felt we needed to introduce. So there were a total of 13 challenges identified, encompassing environmental, personal and professional issues. But out of those 13, three main themes emerged. The first was lack of experience. They felt very, very frightened about identifying when the baby was actually getting worse and becoming close to death and knowing what to do at that time. The second was lack of competence, being able to show empathy and involve the family appropriately at that particular time, including making memories. And this is an area where we really have not been good, really as good as we could be in the neonatal unit. Lack of knowledge, they were scared of not providing the right kind of comfort measures for the baby who was dying, and they needed more guidance from the senior staff. Lack of experience, yes. They felt that they were inexperienced in identifying when the infant's condition worsened, and that impacted on their confidence. Because if they felt that they were in a room with parents and their baby was actually becoming worse and their condition was deteriorating, and they weren't able to recognise that, and parents would start to ask questions, that they would feel really bad and feel quite, insecure. There was a palpable anxiety with these students about caring for a dying baby and their family, but most of them were willing to take on the challenge as long as they actually had the right amount of support. So there were some quotes for some of the participants. We don't get the opportunities to care for dying babies. More senior nurses always get to do it in our unit, and that is so true. It's the same in midwifery. When there's a mother comes in with an absence of a fetal heart, very often it's always the more senior midwives who will get to care for those mothers, and it's the same in the neonatal unit. Parents pick up on our lack of experience, and they may want someone more senior to take over their baby's care. And imagine how awful that would be for you as a professional. I'm afraid of seeming disconnected with the parents, not acting appropriate or saying the wrong thing at the wrong time. So those were just some very honest, quotes. So there was a professional and a personal struggle in that they wanted experience of caring for these babies, but they were frightened that they'd be left unsupported. There was a sense that there were more senior nurses always had the monopoly on this, and that they were never going to get the chance to do it until some night it was busy or there was no one else and they were put in that unenviable position. Junior staff wanted the opportunities to learn about what they perceived as a specialised care, but they would avoid it in case the support wasn't there. The second theme was lack of competence, and they highlighted anxieties around their own lack of ability to show empathy in a way that did not overstep professional boundaries. One of them said to me, is it all right to cry in front of mum and dad? Is it all right to put your arm around a mummy if she gets really upset? These were, they may seem small things to some of us, but to them it was a big thing. Being unable to involve families in appropriate and meaningful way of care, and facilitating memory making. Now again, we would have done the thing like the footprints and the handprints, and if mum and dad wanted to cut a wee lock of hair or something like that, but other than that we really weren't doing very much. And I have to say, by linking in with our children's hospice, we've had some fabulous sessions, both at our neonatal conference and in the university. We've had some really good sessions where the staff have come in and have just been absolutely phenomenal in showing us very simple but effective ways for our nurses to make memories with the families. It's been really good. So some more quotes: I would want to balance being there with not giving enough support. I'm not sure I would know how to involve parents in making memories for their baby, so I'm hoping very soon that will not be the case. Competences included meeting the baby's physical needs and sensitive and complex communication with parents. They recognise from literature that the impact that what you say and what you do has on parents at this particular juncture can last for a lifetime. So they were extremely anxious about it. They feared doing or saying the wrong thing and becoming upset in front of parents. They had a fear of being able to assist parents in making memories, and that they knew could impact very negatively on their grieving process. And they feared that the experience that they would get, was, they needed that to develop the competence, but they needed to have the experience on a more regular basis. The third theme was lack of knowledge. Anxiety caused for the nurses by what they perceived as their own lack of knowledge regarding care. Support included guidance from more senior staff or a care pathway that would give them triggers to follow. And it was amazing, even though Alex's care pathway had been published at that point, that some of these students still were not aware of it. They didn't know it existed. Such guidance was seen as a potent method for them of decreasing their anxiety and increasing. Knowledge is power. The more we can teach our students and our junior nurses about this, the more empowered they will feel. So some of them said, my priority is making sure the baby is comfortable, but I'm not sure I'd have the knowledge or confidence to do this properly. And that's an awful way to feel if you're caring for a baby and the family at that particular time. I need to know what to do for the baby. I'm scared of missing any details in the documentation. So there was a very real fear they didn't have the required knowledge to deliver end-of-life care, and that caused them great worry and anxiety. And some of these junior nurses actually said to me, Sharon, nobody in my family has died yet. I didn't experience any death of a patient in my nurse training, so I really don't know what happens at a time like this, and I don't know how I should behave or how I should deal with the family or help them. And some of them, and a few of the others said, yes, that's true, nobody in my family has died yet either, and I kept forgetting that I was a bit older and they were also young, but it was very obvious that it frightened them. The lack of knowledge included aspects such as pain and symptom management for the baby. Regarding signs of deterioration, this came back again and again, knowing what to look for and how to recognise when the baby was actually nearing death. Documentation, what to fill out, and then after death care, what they should do afterwards to support the family. So future developments for care, collectively 9 initiatives were identified across the groups, and we ranked the top 3. So there was multiple opportunities for training and education, both externally and in-house. They all were craving for more and more teaching. But as Alex has already alluded to, releasing staff in these days when we're so short everywhere is a real challenge. Improved support of junior nurses in gaining experience where they could further learn and develop their existing knowledge skills in a very practical way, such as buddying along with senior members of staff. Perhaps not doing anything terribly active in the room, but just watching how someone senior deals with a situation like this, how they speak to parents, their body language, what they do for the baby. Just standing in the corner and just observing all of this, even I think they felt would be really, really useful. Feedback from previously bereaved parents would be important in shaping future care. And they were reminded there was a plethora of literature out there from bereaved parents, so it's just a matter of them accessing it. Other suggestions were more courses on end-of-life care and bereavement follow-up, and information packs for junior staff offering a point of reference when required. So even if it was just a tick list of little things that they should go through, I think they felt that would be helpful. Debriefing was another support strategy that they identified as being important to them. There's a lot of it goes on now in nursing and midwifery. And they felt that this would help them to learn in terms of confidence and knowledge building, that by talking through a situation like this afterwards with a senior member of staff, that they really could learn a lot. Enabling them to, nurses with less experience to express their emotions. Some of them were so frightened of being perceived as being weak if they cried. in front of other members of staff. And that shocked me. I really didn't think that they would feel like that, but they did. They felt that maybe the sister in the unit would think that they weren't capable of doing that sort of thing again, so they may not allocate her to a baby again if she was going to become upset. So I think it was good for them to realise, to talk to senior members of staff and understand that, we all get upset, of course we do. And it's just maybe mechanisms how they could actually manage their emotional reactions would be helpful. So the way forward, the discussion and the strategy suggested gave rise to two interrelated themes, which clearly housed all the solutions that they gave it. And it was this anything to decrease the pressure of getting it right. And I suppose in some ways as their lecturer, I probably put more pressure on them by saying things like, you don't get a second chance at this. You get one chance at doing this properly. There are no rehearsals. And so it is important that we do educate our staff and that we do get it right first time. So it's important that there's appropriate support and appropriate education and training, as these mechanisms were seen as important in buffering for them this pressure that they were experiencing. So one nurse said it would be good to have the chance to talk through the experiences with senior nurses to find out what we did well and what we did that wasn't so good so that we might learn from this. Support was another theme that arose, and they felt that the strategies that we put forward maybe would enable them to develop the competence and knowledge and experience in a supportive environment, and the emphasis there is on supportive. There should never be, we should never be critical, obviously, and they need to feel that more senior staff with more knowledge and experience are supporting them at this difficult time. So some of the quotes that they gave us were, that they would like more teaching around symptoms and observations, knowing what to look for and how to respond, more feedback from parents after they leave the unit, to learn from that, and more study days. Well, everybody would like more study days, but whether we ever get it's another thing. Appropriate education and training was viewed as crucial, whether that be in-house. And I think now, working in a university where we see our commissioning money dropping every year, it's very much, I think, we're turning more to in-house training. So it would be good if we could actually organise a lot of these training sessions, as Alex does, in the hospitals themselves. And research does suggest that our current education provision for neonatal nurses does not meet their distinctive needs, and we need to have more focused educational input. And more education around alternatives. It's only in the last couple of years, I would say, in Northern Ireland that we're really starting to look more to the hospice. And I'm sure the staff in Belfast would agree that they're getting more and more referrals from neonatal units over the last couple of years. So the collective findings indicate many challenges for caring for babies at this point, leading to fear and anxiety in these more junior nurses. The awareness of the nurses, even when junior, that the day that a baby dies has a lasting impact on parents' bereavement and grief reactions, and exacerbates the anxiety these nurses feel in the attempt to get it right. And again, fear of the caring for these babies can cause much work-related stress. The neonatal unit is a stressful place to work in as it is, but I think issues like this can really exacerbate that. So recommendations that they gave us were that, of course, the voice of parents should be central to all of our teaching, that we need specialist training and education and support, that nurse managers should think about budding systems. Now, I know, again, that's not always easy. We can't always forecast when a baby is going to die, and staffing levels are going to vary from shift to shift, but it would be really good if we could have some sort of a budding system where junior members of staff can link up with more senior staff. Greater collaboration between education and service to develop curricula that integrates education into everyday practice. And I like to pride myself on that, and that I do meet with neonatal managers on a regular basis, and that we do very much try to link in with the hospice and other disciplines to develop our curriculum and make it effective. And availing of expertise from sources like our Children's Hospice. So this study enabled the often unheard voices of junior members of our nursing staff in the neonatal unit to be heard. And as well as gathering what I think was valuable data, it went further to explore the participants' learning needs and looking for a way forward. We were trying to explore current gaps in education, and we're trying now to make provision to make sure that we can address these in the future. So the future would be that we need more research. The research, that we have out there, a lot of it is around ethical issues and decision making. There's not an awful lot about how nursing staff feel. And some of my medical colleagues actually were quite shocked to discover that these junior nurses actually did feel a wee bit scared about caring for dying babies. To which I replied, they were very senior staff, to which I replied, well, how do you think your junior doctors feel when they come into the neonatal unit for the first time and they have to deal with this? Why would our nurses be any different? There needs to be ongoing education and support across the professions, and we're in Queen's University particularly, we're very much into developing IPE, and we're using much more simulation, which I think will be invaluable in an area like this. And we need to have more collaborative working and options for families. And we do work quite a lot with Tiny Life. It's our local charity in Northern Ireland. We do work very closely with them as well. So I'd just like to acknowledge my students who were very patient, and I did provide them with a lovely lunch the day they stayed, mind you, to help me with the interviews, but indeed they didn't have to, and they were very, very good. We did have people there for support just in case anything became distressed that day, but they were all really fabulous. And Dr. Kevin Hugel, who was my supervisor when I was completing this dissertation. And the last thing I'd just like to say is in Northern Ireland, our neonatal network is developing, we're currently working on developing a pathway, a perinatal palliative care pathway. At the minute in Northern Ireland, pregnant mothers come at 18 weeks for an anomaly scan, at which time they may be given a diagnosis of a life-limiting condition. Currently, to our shame, they leave the hospital and really don't have any support other than if there's a bereavement midwife available in that hospital. And you know, they live the rest of their pregnancy really with limited support, and nothing further is done until they come back in to have their babies, at which time then there's a last-minute scurry to see where are we going to care for this baby, what options do we have, and it's not the right time to start to do all of that. So we're working very hard at the minute. We're collaborating, I'm really glad to say, with our colleagues in the Children's Hospice in Northern Ireland, and again, their input has been invaluable because they're the experts, and we're very much depending on them to guide us in how we can develop this pathway. So now we're hoping that when the mother gets that scan at 18 weeks, she'll be referred immediately to the bereavement midwife, and that from that we can start to devise a care plan for the family and for the baby at birth, so that we're not running around at the last minute, that there is actually a plan of care in place and that the right people have been communicated with. So we're really excited by that. As I said before, my introduction into palliative care was almost accidental through my friendship with Jane Price, but I'm so delighted to be invited onto the special interest group in Belfast, and you know, through that work, my work has taken a completely different direction, and I'm really hoping that together, collaboratively, we could provide a service in Northern Ireland that will be, you know, effective, and that will provide the very best care that we can for the mummies and daddies and the families, and of course the babies for the duration of their life. Thank you very much for your attention.